It's 12:01, so I think we'll begin. I want to thank you all for attending this meeting. This is the ad hoc advisory group to review and update the Colorado Hospital Crisis Standards of Care. And as you can obviously tell just from the number of people that have signed in, this is an open meeting and media may be present. Many of us
sounds like the item that Billy was trying to find out for us yesterday about.
And if Dan, please mute yourself. If you're not speaking, I would ask that you mute yourself so we don't have any back talk. Many of us know each other, but I'd like to go around and with brief introductions, if you could give a 2-sentence description of yourself for the people that are actually the invited guests. We won't run through everyone. That would take half of our meeting time. Anuj, let's start with you.
Yeah, I'm a pulmonary and critical care physician at Denver Health and have been involved in crisis standards of care since the beginning of the pandemic.
Matt, how about you?
Sure, Matt Winnie. I direct the Center for Bioethics and Humanities at the university. My training is in infectious diseases and public health and bioethics. And I will have to leave after about 20 minutes. I have to run to clinic, sorry.
Right. Yeah, thanks. We appreciate you coming in. Claire?
Sorry, I had to find my mute button. Dr. Claire Ewing from Centura Health, serving as the Vice President for Healthy Communities. And I'm an emergency physician by training.
Okay. Amber?
Hi, I'm Amber Schwab. I work for CDPHE and am recording and hosting this meeting.
Yeah, she's one of the people that makes this all work. And Shannon?
Hi, I'm Shannon Rossiter. I'm a policy advisor also here at CDPHE. It's nice to see many of you again.
Patty Mayer, sorry.
Hi, Patty Mayer. I'm a physician. I'm the Director of Clinical Ethics at Banner Health, and I was the coordinator of the original Arizona triage protocol. Thank you for having me.
Thank you for coming. Peter Pons?
Hi, Peter Pons. I am a now retired emergency physician from Denver Health and a former EMS medical director.
Michael Roshan?
Hey, it's Michael Roshan. I'm an emergency physician by training and I have a PhD in virology, and I am with Centura and the medical director of the COVID service line for Centura.
Good, thank you. Colleen?
Good day, Colleen Casper, a nurse and Director of Policy and Practice for the Colorado Nurses Association. Nice to be here.
And anyone else that's an invited guest that I didn't call on?
Me, Barbara Statlin, hospitalist at Denver Health, and it was active earlier in the pandemic as well with us.
Good.
And Jeff Sankoff, emergency physician, Denver Health.
I'm sorry, it's very hard to call people on the list they give you from Zoom. I apologize. And then Darlene is just signing on.
Hi, it's Eric France. I'm the Chief Medical Officer at CDPHE, trained in public health and pediatrics.
Good, thanks. Well, Darlene is still connecting. So the purpose of today's meeting is to look at some of the issues that are facing our hospitals currently and review and update our current hospital crisis standards of care in terms of those issues. And to wit, Dr. Anuj Mehta has taken the bull by the horns and put together a draft that many of you received. It is just still a draft, which addresses some of the issues that unfortunately may be forthcoming. Before that, Eric, would you like to say a few words since you're the...
Yeah, thank you, Steve. First, my thanks to all of you for coming together over the lunch hour today to have this discussion. I think you all are aware of the state that we're in right now with the expanding pandemic cases and the stress on hospitals, and that we've activated the crisis standards for staffing and may need to activate crisis standards for medical care in hospitals. And as folks on this call, experts have advised me, the current hospital crisis standards really could be expanded based on our experience. And so I appreciate you all pitching in and helping us think about how to revise these. They will ultimately be revised, taken back to the GERC for approval, and then the governor could then authorize their use, at which point I can activate them if they are needed. So I thank you for the work, and I appreciate you all leaning in so quickly.
Thanks, Eric, very much. Anuj, you wanted to take us through. Do you want to drive or you want me to drive?
I'm happy to drive, and thanks everybody for being here. And for those of you that have sent me comments, I unfortunately have not had a chance to incorporate all of them. But also just to recognize that similar to the first go round in March 2020, this actually was compiled in somewhat of a faster timeframe, despite the monumental nature of the last document. We actually did that in 2.5 weeks before it was presented to the GERC. This we're going on 5 days. When we kind of first talked about the need on Friday. And from a clinical perspective, as a critical care physician, I just see we're utilizing far fewer ventilators at this point. And most hospitals, not all, but most hospitals have good ventilator reserves. We're just seeing limitations in workflow in other areas. And this is also reflects my growing understanding of crisis standards of care, that crisis standards of care is not just triage, that there's multiple steps that you could theoretically take or be in where you alter your standard of care, you change your standard of care, that's a crisis. And the last step is triage. And by triage, I mean, unfortunately allocating certain resources to some patients and maybe other patients receiving less than standard, or allocating more palliative options to them. So this is open for comment to all the invited members. Again, it's a draft to everybody here. It's by no means the final version. It's not, also doesn't have to be the version that we adopt. Steve, I think actually you've disabled sharing, or whoever the host is. I'm sorry, I can't share my screen.
Oh, that's, yeah, Amber, can you make sure that Dr. Mehta can share?
Perfect, thank you so much. Okay, so the first step actually was thinking about the title, because this is really meant to be all-encompassing, and it recognizes the fact that we can't necessarily have a triage score for everything. So I titled it Crisis Standards of Care for Hospital-Based Triage, really highlighting that this is everything from inflow through the emergency department and transfers to outflow in terms of discharges, and doesn't really, we're not talking a lot about how we would allocate outpatient care, other than some patients may be triaged to receive outpatient care instead of inpatient care. I mean, the introduction, I think, really needs no great debate here, other than highlighting the fact that we are in another surge. And then I think this language here is important, kind of highlighting the fact that many other factors may need to be triaged if the current trends continue. Specifically, emergency department capacity, hospital capacity, dialysis is becoming a shortage, medications in the hospital, oxygen delivery systems, heated high flow oxygen, other than ventilators, for which I think we have a plan, and then staffing shortages sitting at the center of a lot of these issues. Everyone feel free to interrupt me. There's no formal approach to how we do this. I think the key thing here is really laying out the core principles and then guiding principles of triage, and utilizing multiple examples of ways in which this could potentially be implemented without mandating a certain strategy for that every hospital has to follow. So these are the core principles. They are very similar to what was in our previous document for hospital triage for ventilators and ICU beds. Yeah, go ahead. Oh. If somebody's not on mute and they don't have an active comment, please mute themselves. BN, I don't know who that is. Thank you. So, one, that this is really meant to ensure transparent, consistent, equitable, respectful, and fair care for everybody. That ideally, and I use the word ideally here because it may not be possible in all settings. Ideally, a triage team who does not have clinical relations with the patient should be the ones making that. And the triage team, ideally, again, could consist of somebody from a palliative care ethics department, hospital leadership, inpatient medicine, and that could be hospitalist, critical care, emergency department, and then also, I think it's really important that we have nursing representation because a lot of these decisions impact nursing. Those are the people that would implement this plan on real time, but you can obviously modify that. And then recognizing that certain smaller facilities, especially critical access facilities, may not have all of these resources, and that there may be some decisions that the triage team doesn't have to have day-to-day involvement with. That the framework should ideally be implemented across the state to reduce variation. And the Colorado Hospital Transfer Center, I think, is really helping us avoid regional exhaustion of resources. That we don't have any categorical exclusions to care. Specifically, no triage decision should be solely based on age, race, ability to pay, disability status, et cetera, et cetera. And we actually really had a long list because I think all of us felt that the ethical framework was so critical. That the triage framework employs multiple clinically relevant considerations, but should not include any single categorical exclusion. There's nothing for which we're gonna say, just because you have this and only this, you're not gonna receive care, you're gonna receive an altered form of care. And that patients who are triaged to not receive a resource should really receive the optimal care within the triage framework. And that could be outpatient care, that could be palliative care. So really, this is not triage to no care. And I think that's important for everybody to remember. And, this is, I think, really critical. And this highlights the impact that I think, unfortunately, unvaccinated Coloradans have had on all of us and the general public, is that the triage process has to apply to everybody. It's not just for COVID patients, as we know that there's a high percentage of non-COVID patients in the hospital as well. And then this is an addition, just to clarify what we should be focusing on. This is different than, and this is also based on some commentary from the Office of Civil Rights, OCR, that really we should be focusing on short and near-term outcomes, that any evaluation of longer-term outcomes, one, is less accurate because our prediction models are not as good, but also may incorporate greater bias against certain populations. Yeah, please go ahead.
Dr. Mehta, I just wanted to call out the categories for exclusion. I know there's been some bias, especially amongst healthcare workers, for the unvaccinated. So I wonder if we might want to call that out as a exclusionary category, that we are not going to change care based on whether you're vaccinated or unvaccinated.
I think that's really important, and I suspect that that's going to be a lively discussion point. So I'm just going to write that down, and let's circle back to that. That is a national discussion point right now. I agree with including that as something that should not be part of the triage protocol for a variety of reasons. So section 3 is just areas, it's examples. Again, most of this document is examples of areas of potential triage and examples of potential solutions. So emergency department workflow, which again, I am not an emergency physician. We have multiple emergency physicians on this, so I would appreciate greater clarity. But in my mind, I think of a couple different workflows. One, there's the patient presenting to the emergency department and they receive a medical screening exam that's actually called out in EMTALA, some of the EMTALA statutes. And then they enter the emergency department for an evaluation by a set of providers. And then a decision is made for discharge versus admission from the emergency department. Obviously, it's far more complex than that, but you can imagine the capacity can be strained at any area along those ways. And so I highlight that as kind of areas where triage may be necessary. Triage may be necessary if could be made about the benefit of transferring patients to another institution. So if you have 6 people who need to be transferred, there's only 1 bed that can be accepted. A triage decision may need to be made about which patient would be the most appropriate for transfer. Similar, some hospitals may receive multiple requests for transfers, and they may have to decide which patient is most appropriate to accept. A lot of this could be done at the level of the Combined Hospital Transfer Center. So I just want to call that out, that this is not mandating that this has to happen. These are just some areas. there may be limited capacity to admit patients to general medical or surgical service. So again, we have a protocol for intensive care beds, but those protocols don't necessarily apply to the general medical ward. The SOFA score and the modified Charlson comorbidity they don't really provide predictive capabilities for just general medical admissions. Non-ventilator oxygen delivery devices, renal replacement therapies are some areas. Medication shortages. We know that tocilizumab is a medication that has been recommended by the NIH, and it's some severe shortage across the United States. And we've been using alternatives like baricitinib. That's another form of potential triage in a hospital. And then, this idea of rapid discharges. So are we able to identify patients potentially in the setting of constrained capacity who maybe they would remain admitted to the hospital for a couple of extra days to complete medical therapies, but they may be safe enough to be discharged in the setting of crisis? And I think that concept of safe enough is critical. So this is not all the forms of triage. Again, this is a series of examples. Critical actions to be taken before a hospital triage is implemented, and I commend Dr. France and the state for actually doing most of this already. But activation of the combined hospital transfer center to level 3, which we're at right now, activation of crisis standards of care for healthcare staffing, which obviously happened on Tuesday, alterations to standard therapy before full triage. Some of this is actually written to the crisis standards of care for healthcare staffing. So this idea of altering patient ratios, so we don't have to deny anybody care, but maybe, it's slightly less optimal. I mean, that is a form of crisis. 1 to 2 ratios for continuous dialysis, or even, spacing out dialysis if need be, or cycling dialysis to ensure that as many people can get treatment. Suboptimal. People are not getting their full prescription of dialysis. And then reduction or temporary suspension of non-urgent surgical procedures. We know that the governor's executive order is applied to cosmetic surgeries. This may need to be expanded, and I already know that some institutions are limiting some of their less urgent, like non-urgent procedures to augment capacity within the hospital. And then establish pathways for more urgent outpatient follow-up. And this is not being done, I think, across multiple systems. I think there are a lot of attempts to do so right now. But this idea of if we're either not admitting patients to the hospital or we're doing early discharges, we may need to have more robust outpatient follow-up mechanisms. This includes evaluation by healthcare providers, which I specifically call out the ability for telemedicine to do that as well. And so authorization of telemedicine, I think, I know we've listed a lot of the limitations of telemedicine during the pandemic, so continuing to do so, but also having institutions and the state, not in the form of mandate, but really try and support the durable medical equipment needs of patients. There are multiple patients across the state that are hospitalized because they're still on oxygen, and they maybe are undocumented or lack insurance, and they can't pay for outpatient oxygen. And if we were able to support that in the setting of crisis, they may be able to be discharged. I mean, we don't have to wait for crisis to do so, but I call that out specifically that these outpatient follow-up and support systems need to be in place to alleviate the strain on hospitals. I talk a lot about triage teams. We've gone through that a lot. We highlight a lot of this idea of what's the ideal situation for a triage team. Yep, please.
Hi, I want to just do a process check, if that's okay, Dr. Cantrell. Mostly that knowing Dr. Winia will be stepping away, this is a great overview, and I want to be sure that if Matt has any particular thoughts or comments, even if they jump ahead a bit, we hear him before we lose him.
Thank you so much. I really appreciate it. I would just make 3 kind of question/framing comments that I think one of them goes back to the initial and one will jump forward, but I appreciate the opportunity since I will have to jump off in a minute. I think it is really important to recognize that our original documents really focused a lot on the ability to assess who is likely to go on to die, even if they get critical care resources, and to withhold services from those who are most likely to go on to die anyways. So the SOFA scoring, all of that is about predicting mortality, even if they get a full court press. And I think what we are largely talking about with most of these dilemmas is the other end of the spectrum. It's trying to find those people who will be okay even if they don't get a service that they would normally get. So even if they get discharged a little early, even if they go to the floor instead of to the step down, or to step down instead of the ICU. So the predicting models are almost the opposite. We're not trying to predict mortality. We're trying to predict, will you be okay if you don't get this service? And I just think that that's kind of a framing comment, but it relates to my next comment, which is around our intense focus initially on not looking at certain factors: socioeconomic status, insurance status, race, ethnicity. And I think those do not play a role when you're predicting mortality in an intensive care unit. They could actually play a role if you're trying to predict who's likely to do okay, even if we send them home. I would hate to use a criterion that was purely clinical and end up sending someone home who's homeless and keeping someone in the hospital who is wealthy and could very well afford to have someone come in and check on them at home. So I actually think for many of these decisions, we actually have to look at socioeconomic status. We have to look at their social supports. We have to look at their ability to take care of themselves if they don't get admitted to the hospital. And it becomes, I think, impossible for the triage team to do a good job at this if we don't give them access. So we were trying to be sort of colorblind in our approach last time around with critical care, ICU ventilators. And I don't think you can do this in that kind of a manner when what you're asking is it okay to send this person home when we normally would have admitted them? So I think the triage team in some of these instances is going to have to look at that. And then the final thing, which I realize is a little controversial, but this question of what is the role, if any, of someone's anticipated or actual length of stay and the volume of various resources that someone may be using. And, in a sort of strict utilitarian calculus, you would be looking at, well, look, if we could save 3 people with these resources or 1 person with these resources, we should save the 3. I don't have an answer to this, and I certainly am aware that we do not want to create a protocol which puts people with disabilities at a disadvantage. And at the same time, when we start talking about issues of, how long is someone going to be sitting in the ICU before we reassess them and decide, should this person be moved to palliative care, to comfort measures? I think we almost certainly are going to have to grapple with this somehow.
Thank you, Matt.
Sorry to leave you with that one because that's the hardest, but.
I appreciate you having a chance to share your views before you jump. Thanks so much.
Eric, I think it was a great stopping point that you highlighted, and see if anybody else has comments. What I will say is, while not highlighted here, Matt did send me some comments that specifically called out this section that's highlighted on my screen about this idea of that socioeconomic status. And I was going to modify it. I actually think it's a really critical point. I think the way to view this is that in terms of making clinical triage decisions, such as somebody who may be low risk for readmission, utilizing say we used a pneumonia severity index. So, and identifying those people who may be low risk, so maybe don't need to be admitted to the hospital, that should be blinded as much as possible. But then actually making that final triage decision about, okay, well, they still need oxygen or they actually need antibiotics, may require some socioeconomic status input into it. And there's actually commentary later on about how we have to ensure that people have appropriate follow, like they have to have access to what they're triaged to. And I think that's really the key thing is, you can't triage to somebody to outpatient care if they don't have access to outpatient care, either because they don't have a doctor, they don't have access to a doctor, they don't have insurance. And so I agree with you that we need to incorporate that language. But this is a good stopping point to see if anybody else has comments, or I can run through the rest of the document more quickly, because these are just examples.
News, I would just make the point, in emergency medicine, we've been making those decisions literally for decades. You can't send someone out for outpatient treatment of pneumonia if they're homeless, as an example. So that really does, it always has factored in. So I think it is appropriate to include that here.
I've been working on taking longer time for pauses, actually, and being comfortable with that. So,
if we were to include that socioeconomic status into the triage tiers model, where would that fit? Just a question.
So it's interesting. I'm going to jump, based on what you're saying, Claire, I'm going to jump ahead down here to actually this idea of tiers. So when clinical factors are not sufficient to make the triage decisions, this is really different than ventilators and ICU beds. And it's not just special populations. It's essentially, when does the clinical situation not actually tell you who should receive a resource? And then that's where the ventilator system had tier 2, which took into account healthcare worker status, first responder status, pediatric patients, tier 3, pregnancy, essential workers were added, given the risk of exposure based on, them continuing to provide us with food at the grocery store. I actually think this idea of socioeconomic status is a clinical factor in making that decision. So I think that belongs in tier 1, because again, if you don't have access to outpatient care, then that clinical pathway, treatment pathway, is not a realistic goal for you. So I would elevate that, and I'll work it into the language here, that would be at tier 1.
Anuj, if I could make a suggestion, I think maybe not using that term, but spelling out what you're talking about.
Yes, of course.
Do they have a home? Do they have ongoing follow-up with a medical care provider, rather than just the general term, which I think is a very loaded term?
I agree, and I think actually what I've hopefully tried to avoid doing is using terms. And again, this is where everyone's input is really critical, is because these are examples. We're not going to think of, in this group or any group, every example in which somebody's non-clinical factors may affect whether or not they have access to certain types of care. So I think giving examples of situations: can't discharge somebody for home pneumonia treatment if they don't have a home. Can't discharge somebody for outpatient COPD therapy if they live in a shelter without access to nebulizer, or things like that. Okay, anybody else with comments before I just kind of run through? I know we're we're on the half hour, and I want to be respectful of the lunch hour.
I guess the only other thing that crosses my mind as you're going through this, and probably something on your mind too, that it all begs for another kind of flow chart of some kind that kind of clarifies, as painful as that can be, and used to create them, but you're clearly saying that, well, combined hospital transfer centers should be at level 3, and that marginal critical care person, you should have those floors open to take care of them before you go to the next level, and so on. And it just feels like it kind of lays out with certain criteria before you get to where these difficult places can be. And then there, you'll have that decision of these different other things about capability for care at home and so on.
Yeah, I agree. And I think, Eric, what you speak to is even the potential for a phased implementation of different levels of crisis standards of care based on that flow chart. The other thing that I comment on, and this was actually Barbara brought this up, is that if things get even worse than predicted over the next month or two, and say we see a massive flu surge, there may be situations where the triage team can't make every triage decision, and that we may need some automated systems. And not by automated, I don't mean like computer-based. I mean algorithms that clinicians can follow that are decided upon by the triage team. For example, and again, only examples, in the emergency department, I think that a lot of emergency departments are risk averse. So they choose to admit patients that may be borderline, where scoring systems may dictate that they could otherwise be discharged. But if a triage team were to say, okay, everybody with a pneumonia severity index below this level should be discharged if they have adequate follow-up and all the other access to care, that may be an algorithm that can be implemented potentially in the emergency department without direct consultation with the triage team, unless the clinician wants to take a different route. If the clinician feels strongly that somebody should be admitted, they're not. They can consult with the triage team. So I wanted to at least create a workflow where the potential exists for the triage team to create algorithms where they don't have to be involved in every single decision. If we enter situations where only 6 or 7 triage decisions are made a day, well, maybe that is something that they can handle. But there's the potential that it's much worse than that. And also, I think that a lot of emergency departments, if you don't want to delay their workflow with a 2-hour deliberation about who should be admitted for low-risk chest pain, right? So we don't want to force that. So I at least created it so we could debate that. And then I think this is really the heart of the matter. And this is a little bit what Matt was talking about. Without coming up with a single score for everybody to use, what should the principles be that the triage team should make algorithms with and should make decisions upon? And I think it's how likely is the patient to survive and not require readmission or reevaluation without the resource being considered. And that's exactly Matt's point. These are different than the ventilator decisions about who's the most likely to die. This is who's the most likely to be fine without the intervention. We know that we provide things to patients all the time. That's part of our healthcare system that may actually not need the level of care that they otherwise receive. Second, how likely is a patient to survive, not require readmission, reevaluation if they do receive the resource being considered? So this is the opposite side. This is kind of where the ventilator aspect was viewed. And I know the wording, I chose the wording very carefully, because if a patient is not going to survive, even with the intervention, then that's a potential time where we should be thinking of alternate pathways like palliative care. And that's exactly based what the guiding principles were for ventilator triage. If I give you a ventilator and you're still not going to survive because your SOFA score is so high and you already have stage 4 cancer and you have all these other chronic comorbidities, well, then you should receive another form of care. And then finally, and this is, I think, the wording needs to be modified. Does the patient have access to an alternate level of care? And this is the question of, do they have access to this alternate care pathway? Whether it's outpatient care, if somebody's triaged not to receive an ICU bed, but to receive care on the floor, is there a floor bed for them? Those types of things. And I think I'll obviously rework that, redo the wording. And then, obviously there's some examples here, right? A patient with DKA may have the worst laboratory abnormalities you can imagine, with a really high risk of death with no intervention. You treat them for 24 hours and their risk of death goes to virtually 0. And that's an easy example of someone who looks like they're going to die, but the resource is going to treat their condition. And so again, guiding principles. Similarly, somebody with, and again, no direct exclusions, but somebody with advanced cirrhosis, decompensated cirrhosis without a pathway to transplant, you can provide them with every critical care resource and their mortality in 30 days may not change. So I come up with several different examples where triage may be applied and maybe some ways to do it. So rapid patient discharges. So these are maybe identifying people who have near completion of medical therapy. In some cases, we may keep patients until they complete IV antibiotics, until their glucose is fully titrated based on their insulin is fully titrated. But there are several scoring systems, and these are just a couple of them. The hospital, the LACE, and the NEWS2 that identify patients who are at very low risk of readmission or representation to the hospital, even if they haven't fully completed their medical therapy. So these may be systems that could, and again, I'm not recommending any scores, but I do have a composite cutoff of all 3 scores who could potentially be discharged 1 or 2 days early. And that would alleviate some of the capacity if they could go home. Transferring patients. So again, you could imagine situations where—
Anuj, maybe before we go, just a quick question on the 3 questions you listed above, where you mentioned it starts with how likely is a patient to survive, and are there times where it's not so survive, live, die kind of thing, because sometimes people are admitted to a hospital for, a very painful injury that they would certainly survive if they didn't come to the hospital for management of it or something. And yet they may still have a high priority? Or do you think in this time that it's really about survival, and that's actually a very specific language on purpose?
No. So the language I think I chose, survive and not require readmission or reevaluation. So if we're discharging people or sending people out from the ED to only present tomorrow with the same complaint, again, you're a perfect example of somebody that doesn't have a life-threatening condition, but they're going to represent until they have some degree of treatment. If they're going to come back, then that patient should actually, based on this principle, be readmitted. So I think the way to view this is not how likely is the patient to survive, how likely is the patient to survive and not require readmission or reevaluation. And that global concept is about healthcare utilization, I think. And I think that's how we should be thinking about it. Yes, eventually it may have to be, how likely are you to survive? I mean, in a real dire straits, that may be how we limit it, but I think we're not there yet. And we want to be thinking, we want to be very careful. We don't want to be sending people out to only represent either the same hospital or a different hospital the following day. Because that's a waste of resources.
Maybe the word I'm looking is for like something to improve without care or something like that, because there may be conditions where we aren't really doing that much except some support, whether it's IV fluids or antibiotics or something, and or something where hospitalization is going to help them. However, if they weren't in the hospitalization, things would probably come out well, and they wouldn't necessarily be back the next day.
Yeah. I think we're agreeing with what the spirit of this could be. Yeah. We can tweak the wording for sure. This idea of transfers, we've talked a lot about getting patients to skilled nursing facilities, long-term care facilities. I'm not going to rehash that, but that should be part of this, is figuring out ways that we can do that more carefully, recognizing that sending people to understaffed skilled nursing facilities is not a solution. And we know that some of these lower levels of care, like skilled nursing facilities and long-term care facilities, lower than acute care, not less important, but lower in terms of acuity, or have worse staffing issues than we do. Emergency department triage, I would love for some commentary from our emergency department folks on some of the language I use. So this idea of medical screening, so EMTALA requires that everybody go through a medical screening exam. I do think there are workflows where that is done by a trained triage person, oftentimes a nurse, and somebody presenting for a refill on their medication, or low risk musculoskeletal pain, or just maybe inebriated without risk of deteriorating. If that can be evaluated on a medical screening exam, a potential triage point is to decide, okay, you need to go into the emergency department. You don't, and here's a follow-up number for you to call to get your refill or whatever the case is. And I do think we need legal input about what parts of EMTALA have been waived, because I do think some of them have, and that can happen through CDPHE. Hospital admission versus outpatient care. Again, there are multiple conditions that are in the hospital. Because we have so many non-COVID conditions in the hospital, there are multiple conditions that do have scoring systems to identify low-risk patients. Again, identify those people who actually don't need inpatient care and will likely do fine with outpatient care if they have that as a viable pathway, and potential implementation of these types of scores in maybe an algorithmic fashion and again, maybe that would even involve a little bit more risk tolerance in the setting of crisis. So whereas like less than 1% mortality would be the cutoff prior, maybe it's less than 5% mortality is the risk tolerance that we would accept at the state based on these scoring systems. And in the crisis, these are some examples of things that could be implemented. Triage for patients in need of critical care services. And so I could write papers about this because it's one of my research interests. I did not do that. This idea of marginal critical care patients. So there are patients in one hospital that go to the ICU and they go to the floor in another hospital. We know that. And so trying to identify what those conditions are and working with nursing to ensure that we're not overloading the floor with cases that would typically be taken care of in the ICU. So limiting nurse staffing ratios. If patients with low acuity conditions like mild DKA, maybe a COPD exacerbation, or in the extreme setting, even like, people with on a single low dose pressor could go to the floor with appropriate protections for nurse staffing, so that it's not just one of their 9 patients that they have to take care of. We need to have really careful thought about not just offloading. And it has to be in a moment where there's actually space on the floor. And then patients in need of full critical care support, I think we follow our previous guidelines. I think the modified SOFA score, the SOFA and the modified Charlson comorbidity are prior document and actually still give us a lot of input there. Hospital triage, that's another area where you could implement triage, and there are some examples of what could be done, including potentially a triage at the level of the Colorado Hospital Transfer Center. I'm not saying that's what we would do. These are just examples and suggestions to think about. But this idea of the CHTC deciding which patients are going to benefit the most and not necessarily transferring all patients that have a request. And then I go through a lot of different ways of that, and I use dialysis as an example of stuff that still may need to be triaged. And I think it's important to identify that there are cases where we offer dialysis, especially continuous renal replacement therapy. And I know we don't have a statute on non-beneficial care, and it's a loaded term, but I think it was appropriate to introduce here. There's really good data that patients with end-stage liver disease who need dialysis have their mortality in 3 months if they don't have a pathway to dialysis is virtually 100%. Somebody with multi-system organ failure and the indication for continuous renal replacement therapy is acidemia because of some unfixable cause, right? Those patients, that's similar to a ventilator. They're not going to benefit even with the resource. And I think it's important to call that out and say in such situations, that's where palliative care measures should be considered immediately. Considered, not mandated, but considered. Acuity and duration, something Matt was talking about. So if you have somebody who is potentially going to need CRT for a month versus somebody who missed an outpatient dialysis session or ate too many bananas, they're a routine dialysis patient and they come in and their K is 7.5 and they need 1 dialysis session. Again, who are you going to allocate that to first? It's not that you can't allocate it to the first person who may need it for a long period of time, but you may give it to the person that needs it for a short duration first. And similarly, this idea of reallocation. And I have that here, reallocation for treatment failure. We talked about the tiered approach. I think what's really critical, so in the ventilator triage protocol, the triage team is meant to implement a scoring system. So the biases of the triage team are still important, but less impactful on the final triage decision. The biases in the scoring system still have a huge impact on what the outcomes are. And we know that the SOFA score and the modified Charlson comorbidity score have some biases. When you don't have a standard scoring approach for everything, and it's a more case-by-case evaluation with guiding principles, the risk for the biases of the triage team affecting decision-making increases. And so I didn't mention it here, but one of the comments was this idea of, if possible, if there's time, implicit bias training for triage team members, I think is important, if that's possible. But I really think careful documentation and ongoing evaluations of equity impacts of all triage decisions. So in real time, every few days, people are like, are our decisions disenfranchising a very specific population? And then I think after action reporting, because the framework that we're developing here, this general framework, I think has a lot of applicability for a lot of things, including mass casualty incidents that could happen at any point, but then also, potentially the next pandemic. And so if we have good documentation that can, with standardized after action reporting, we can evaluate the equity impact, the survival impact, and the clinical impact of our actions and reevaluate for the next time, because I guarantee you, this is not the best framework. This is a framework that I put together in 36 hours with the input of a lot of people. And the examples I chose were based on the stuff that I'd heard from a lot of people saying that those are the things that they were struggling with. So I know it took a while to go through that, but I think that's where the document is. And we're taking a lot of commentary, but I want to open this up. I want to turn it back over to Steve and also take all comments about it.
Thanks, Anuj. Let's open the floor for discussion. Any comments?
If I could just comment that I appreciate the fact that you included the information about the importance of documentation. I think what I was reading, I was thinking that you might describe why a patient may be moved to receive a certain therapy, and it may not really say anything about the patient that they had to make a decision against, if there is really 2 people that you need to triage against. And somewhere it seems important to document that the action you took on an individual here was because we were in a triage setting, and this was the situation of the other person, which really isn't relevant to this person's medical record. So somewhere documentation and collection of that would be important. So thanks for that. And I'll just say two other things. One, I was informed that 9 News is live streaming our meeting today. So I just want to be sure everybody was aware of that. And secondly, that Anuj's recommendations here is a very thoughtful and helpful first pass of how we might be moving and approaching this, and still open with much discussion for our finalizing. So I thank you, Anuj, for all the thought you did and all the input you got from others in this preparation. Look forward to comments from others. Thank you.
And just as a reminder, we consider this currently a confidential document. Eventually, it will be released to the public. We would ask that it not be released to the public at this time. It is a draft. There will be a lot of discussion, as Dr. France has mentioned, before this gets released. Any other comments? Go ahead.
I also want to comment on this is crisis standards of care for hospital-based decision-making, which is not currently active. So this is not trying to describe or augment the healthcare staffing that is active. And I'm just looking at a headline right now, and that's why I draw that distinction. This is for things that are not yet active.
Good. Any other comments? Oh, Colleen?
Thank you. And it really is maybe a comment only, not a question, but to Dr. France, is there a way the state plans to create alternative care sites could kind of feed into the outflow dilemmas that Anuj has so well articulated? And again, I don't need an answer. It's just more of a thought. The governor spoke yesterday about the possibility of an alternative care site, and maybe it could be designed with folks who need less than hospital-based personnel care.
Yeah, I think we've recognized already there are patients who are ready to be moved out of hospitals, but don't have a secure and safe space to land in. And so work is underway now that are conversations with our residential care facilities about whether they can expand and open up beds for those kinds of patient transfers. And as the governor announced, there's work underway to expand the number of beds available. Some of those will be acute care hospital beds, and others may be these other beds that are transition beds after ready being discharged from the hospital.
Thanks, Colleen. Any other comments? I have two. One, Anuj, I have talked with Ann Haas from CDPHE in terms of the 1135 EMTALA waiver, and what we had talked about in terms of the MSE, we will be able to incorporate into the document. And that is, it's just a reminder that with the waiver, you can in fact send the patient to another location for your MSE, but you just can't say, well, we're busy, go away. You have to be able to direct them to a specific location where in fact they can then receive the medical screening exam. And my second comment is that I think this is great. I think overall, we have to make sure that what we put together is workable in the real world. It's got to be able to make the rubber hit the road appropriately and not just be overwhelming. But I think we're off to a great start. Do I have any other comments on this great draft that Anuj put together?
Steve, just a couple. I had a follow-up question. So based on the 1135 EMTALA waiver, if a patient received an MSE by a trained triage person, they would not then be that institution would not be legally obligated to perform a full emergency department evaluation if they met the triage criteria to be triaged out.
Yeah, and that doesn't even require the 1135 waiver. Multiple institutions in the Denver metro area have been doing that literally for years.
Okay.
If you come in with an extremely minor complaint, med refill, I think, is a good example. And we can direct you to a pharmacy where you can be satisfied with the medication refill. That's adequate. But yes, that isn't a problem.
Okay.
But just to clarify, Anuj, an MSE can't be done by a nurse. An MSE, according to the EMTALA legislation, has to be done by a provider. Now, I don't know if the waiver changes that.
It doesn't, Jeff, but most places have, what they've done is changed their bylaws to include trained nurses as providers.
I think we can clarify the legalities of that.
We can work on, those are all the details. We'll get that worked out.
And, I think, Steve, I wanted to respond to something else. I think you really highlight that this has to be an implementable document. One of the things we learned, again, after action reporting, is when people tried to set up the triage scoring system, that was very difficult. Not only was it a difficult process to collect the tiebreaker data, even though that was the ideal situation, it was also mentally and emotionally very difficult for the people making those types of decisions. And so I think what's critical for this is to not be overly prescriptive of how an institution has to do this, but provide those guiding principles. And I think that even in the absence of a small institution utilizing a predetermined score, if they can answer those three questions once they're worded better, that's the minimum at which that I think we're really giving the framework for triage is those three questions. And if you can answer those three questions, how likely are you to survive and not require reevaluation without the resource? How likely are you to survive and require reevaluation with the resource? And then what is your access to whatever you're being triaged to? I think that is a guiding principle. And then everything else is just examples that people can choose to take advantage of or not.
Great.
I think that that's sometimes a little bit tricky for folks, especially if you are the triage person, that if let's say you're not obligated to use this triage tool, that then you're left without a tool to make those difficult decisions. And so although I understand the heart of that, I do want to say that we do want to help folks as much as possible with the best data that we have to make those really difficult decisions that they're going to have a hard time making anyway.
Yeah, I think that's really important, Claire. The downside, obviously, is that we don't have scoring systems for, technically, there's actually not a good scoring system to identify which COVID patient could receive outpatient treatment if they had access to supplemental oxygen. And this actually was a comment that Peter Pons made, and I would open this up to the group, is I mentioned several scoring systems that I did in a quick pass from the literature. Would we potentially want to include them in an appendix to saying, hey, so people don't have to look it up? These are things you potentially could use. Nothing has been utilized. These have never been applied to COVID. They've never been applied to kind of the severe strain we have now, as well as limited outpatient capacity. That's something that if people want to answer now or could put in the chat or even in the comments.
Anuj, my feeling would be that with the appropriate disclaimers, it would be reasonable to list those. Yeah. And we have to obviously couch it in just what you said, that these are examples only. There are more out there, but I think things like the Curb 65, that's commonly used. The heart score, commonly used, but I think that would be reasonable to do.
The trauma severity score, we also use that too.
Yeah.
I think, like I just said, the tools that we can give people to help make those decisions easier, I think is really critical. So I would support that as well.
Yep. Jeff, you raising your hand?
Yeah, I was just going to say, because, at the end of the day, I think you're still facing an issue on the provider side. You referred to patients in the emergency department, for example, who have, an intermediate heart score. In a situation where we don't have the resources, that patient, probably should be sent home. But you're dealing with providers who have had an established practice pattern, who have a risk averseness. And I think that's where you're going to have issues. You can write all the criteria you want until you can get providers on board with this notion that we just can't be keeping these people because they're not going to get their, their whatever it is, stress tests or whatever. That is going to require a lot more, I think, effort, is convincing people to go along with this notion that this is unfortunately where we're at and we have to change our mindset.
So Jeff, I think that's really important. One of the things that I talked about actually with a few folks is this idea of the triage team. If a hospital chooses to adopt a certain score, say the pneumonia severity index, then the triage team actually, as more of an algorithm on a daily basis, can set the cutoff. And that cutoff could be one that's more risk tolerant in the setting of crisis, meaning you would accept a 5% risk of mortality. And that would be the cutoff point for the day for that condition. And this is a situation, a triage is a situation where providers have to buy in. Like technically, if I deny somebody a ventilator and an intensivist wants to run in and still intubate somebody and wheel a ventilator in, nobody's going to tackle that person to do so, right? But this is also where hospital administration has to enact the triage, empowering the triage team to have that ability to set the score. And again, I do want clinicians to have the ability to appeal that process. This is not like ventilators where an appeal takes too long. If there was something that really concerned a clinician saying, I know this score is intermediate and this patient should go home, but this person, based on my 20 years of experience, I think is going to have a heart attack in 3 hours, that needs to be listened to. And that's somebody that could be appealed to the triage team.
Anuj, if they tell you that, they're lying anyway. They don't know.
I understand. But I respect the point, Jeff. Yeah.
Yeah, being mindful of the time, I do want to discuss next steps. And what I would propose is, Anuj, what's a good time frame for you? If everyone had their input to you by Saturday morning, would that be adequate for you then to take the comments? And
yeah, I can have it done by early next week.
Okay.
Monday, potentially.
So go ahead.
Steve, I'm sorry. I do want to just make one point. And I think that, Claire, you mentioned this idea of COVID-19 vaccination as part of the algorithm. I think a lot of people have a gut reaction about this idea about people that have chosen not to get vaccinated are burdening the rest of the system. Our ethical principles are to save the most lives, not to evaluate social responsibility. Additionally, CIS went down yesterday for a couple of hours, so you weren't able to query vaccination status. Most of the things I talked about are non-COVID conditions. So if you come in with heart failure and chest pain, your COVID-19 vaccination status is actually immaterial to that. So I agree that COVID-19 vaccination status, at least now, should not be part of this algorithm. And I know that it's a hotly debated thing, and I'm going to let other people comment if they want. But at the same time, people are welcome to send me email comments on the draft form if they don't want to say those things in a public forum.
So if we could have everyone carefully review the draft, make your comments, send that either to me or to Anuj. They all end up in his inbox anyway, by Saturday morning. And then we will tentatively either communicate via email or potentially have another meeting for further discussion. I think it's going to be based on the input that we get. Eric, does that seem like a reasonable plan to you?
It does, Steve, and it seems like ultimately there may be a melding of the two. The two documents are original hospital crisis and then this one, and they become one with different sections talking about broad versus specific issues.
That's one of the things on my list, is to merge them so we only have one document to be read. I mean, this is great the way we need to start, but then eventually I think we do need to meld it in. So, okay. Any other comments? Okay, I thank you all for your participation, and you will be hearing from us. And thanks for in advance for your comments on the draft. Anuj, thank you very much for your presentation. And Eric, thank you for your comments. With that, we'll adjourn.